to achieve over the next few years. And therefore, we sort of defined few objectives. One of them is to improve our presence in medical societies, national and international, optimize learning and extend the knowledge across the kingdom, but not only for trainees, but also for practitioners. Advance research in the field, an area that I think will bring us to the international position, but it will also be important to fill a gap I'm sure many of you can already see. And last but not the least is to drive relevant guidelines and regulations which are becoming increasingly needed as we move into an era of transformation towards value-based healthcare, cost effectiveness, standardization, and high quality, which is nowadays much more beyond a certification. And in line with those objectives, we had few initiatives in mind. One of them is to conduct activities in the form of symposia, webinars, and hence today's online symposium, which is one of many hopefully to come. And we are so much grateful to our partners and our sponsor, GE, for their great support. I have to say, GE has always proven to be a great partner and collaborator, and they have only succeeded in raising the bar. So thank you very much, GE. Thanks again for the RSSA, Dr. Lamia Jamjoom, and for Raya, the secretary for the RSSA. And last but not the least, thanks for the attendees and the participants today for your time. We hope you enjoy the talks. I myself look very forward to them. And before we listen to the first speaker, I am going to introduce my colleague, Dr. Dunya Al-Hassan, who is the moderator of today's symposium. Dr. Dunya is a cardiothoracic consultant radiologist at King Fahd Military Medical Complex in Dhahran. She did her fellowship training in cardiac and thoracic radiology in Vancouver University, Canada. She is now also the Assistant Director of Academic Affairs and Training Department. Dunya, thank you very much, and over to you.
Thank you, Dr. Mashal, for your kind introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome again to RSSA Symposium. As a cardiothoracic imaging group, this is our first symposium and it'll be a virtual event. I hope you enjoy it. Over the next few hours, you will learn some about pulmonary and cardiac infections imaging and interact with images from Saudi Arabia and from around the world. One of the special things about this meeting is that there is truly something for everyone, whether you are a resident, fellow in training, or someone who is practicing for many years, you are going to find a lot of interesting content. This will be an interactive meeting. My colleague, Dr. Tamadar Gazzaz, who is a consultant thoracic and pediatric cardiac radiologist in IMC Center, Jeddah, is delighted to moderate discussions after every session and during question and answers the break, and to receive your questions via the question box. But you will notice as an attendee, you cannot chat or raise your hand as these functions are disabled. However, kindly use the Q&A box that is available for all of the audience. We are, as a cardiothoracic imaging group, are excited and honored to partner with RSSA to deliver what promises to be a premier program in cardiopulmonary infection imaging today. We are excited to bring leaders in cardiothoracic radiology in Saudi Arabia and around the world. I'm pleased to welcome my dear colleague, Dr. Nesreen Abu Rukba, consultant radiologist who is specialized in women, thoracic and body imaging at McGill University. Currently is the head CT unit in King Abdulaziz Medical City, Jeddah, and Joint Commission Assistant Professor at King Saud University for Health Sciences in Jeddah. Dr. Nesreen, when imaging is indicated in COVID-19?
Thank you very much, Lamia, for the introduction. I'm delighted to be part of this group, and inshallah we can bring the best to people. So my talk is about when is imaging indicated in COVID-19. And what I'm going to cover is the indications of imaging in those patients. What are the complications and when shall we image them? What about the recovered COVID-19 patients? And what were the debates that raised during the COVID-19 period, and how did we deal with them? What I'm not going to cover in this lecture is the imaging findings in COVID-19. I think everybody have dealt with these patients and pretty familiar with the imaging findings in these patients. What is the current status of COVID-19 in Saudi Arabia? Well, we have more than 300,000 patients, total confirmed cases in the kingdom. 24,000 of them are active cases. Total number of deaths is about 3,500. And most of the cases are scattered in the larger regions, started more prominent in Riyadh, followed by Jeddah and Mecca, and then the Eastern Province. So what are the indications of imaging in those patients? And I'm going to take you through many case scenarios, and from there, it would be easy to remember the indications of imaging from these cases. So the first patient is a young patient, mild symptoms, and pretty good respiratory parameters. He tested positive for PCR, and if you look at the X-ray, you can see that you would pretty call it normal. And these patients are the type of patients with mild symptoms who were sent previously to isolations in the hotels and nowadays are kept in home isolations. Next patient is an older patient, mild symptoms, normal respiratory parameters, and a PCR positive. Pretty normal CT scan as well. So this patient was sent on home isolation. The next patient is a young patient with mild symptoms, normal respiratory parameters, tested positive for PCR. And I don't have the chest X-ray, but on the scout images of the CT, you can barely see any changes on these images. But on the CT scan, you see these peripheral, somewhat rounded ground glass opacities, which you would call, you would report them as highly suspicious for infections, including COVID-19 in this period. So what we've learned from these cases, that a normal chest X-ray or CT does not really exclude the diagnosis of COVID-19. 50 to 60% of patients actually had normal chest X-ray and CT, especially initially in the disease. CT scan is more sensitive than chest X-ray and can be abnormal even if the chest X-ray is normal. The next couple of cases, this is a patient who is 55, had mild symptoms, slightly elevated respiratory rate, has a positive PCR. And on the CT, you can see these central and peripheral ground glass opacities, pretty non-specific, almost moderate, if I would say. This patient 4 days later developed hypoxia and tachycardia and was transferred to ICU. Another patient, similar clinical presentation, respiratory rate of 30, had positive PCR, but the changes are mainly of ground glass opacities, peripheral in distribution, pretty typical for COVID-19. This patient was, I would also say this is moderate moderate amount of opacities. And 3 days later, the patient was admitted to ICU because of hypoxia and tachypnea. The third patient had more extensive changes on the CT. His oxygen saturation was 89 at presentation, though he had mild symptoms, but pretty extensive changes and more denser consolidations and ground glass opacities at the peripheries of the lung. Also, next day, patient's oxygen saturation dropped, admitted to ICU. In contrast to that, this is an elderly patient, had no comorbidities, presented with mild symptoms, normal respiratory parameter, but had extensive changes on the CT, peripheral consolidations, as well as ground glass opacities. But he did pretty well. He was admitted to the isolation unit on oxygen face mask and was recovered completely and discharged. So what we've learned from these cases that findings of COVID-19 are non-specific. Differentials would include other infections, especially H1N1, SARS, and influenza, other influenza pneumonias, cryptogenic organizing pneumonias, and other inflammatory conditions and drug reactions. Most of the time, imaging will not impact or change patient management. Well, the mainstay is that those patients' clinical parameters are more taken in consideration than imaging. Can we predict disease severity, and can we triage patients according to the CT? Well, I'm going to answer these questions at the end of the presentations during the debate section. In this next couple of scenarios, this is a male patient who presented for KUB-CT with flank pain. This is a case that was given to me by Tamadur. On presentation, he had history of fever 1 week prior to the CT, which was subsided at the time he came to the CT. And in his KUB-CT, there was no stones, there was nothing to explain his pain. But the smart technician noticed some changes at the lung bases, for which he continued with the CT's chest. So the chest CT shows peripheral areas of consolidation and ground glass opacities in this area, pretty typical for COVID-19 changes. He was tested for COVID-19 and turned out to be positive eventually. So what we've learned from this case is if findings are suspicious for COVID-19 found on a routine CT abdomen or neck in a patient who is not known COVID-19, it's wise to continue with a low-dose CT scan of the chest on the spot. Next scenario, this was an interesting case with elderly patients with comorbidities. When he presented to the hospital, he had presented with poor oral intake and dizziness. He had no respiratory symptoms at all. His respiratory parameters were disturbed though. 2 weeks back, he was admitted in another hospital in another region with fever, cough, and shortness of breath. PCR was done there and was negative. This patient had history of close contact with a COVID-19 patient, which is his wife. When he came to our hospital, we did a chest X-ray because of his disturbed respiratory parameters, and it shows peripheral areas of consolidation. He had another PCR in our hospital, and it was negative. So he had a PE study done, which shows peripheral areas of consolidation, and they consulted me at that stage. So what could be this if three swaps, three negative PCRs were done in our hospital. So I said that this patient had a positive contact with COVID-19. He had fever during his admission, and he has those changes on the CT. If he has no other viral illness or no back medical history, this has to be COVID. And the viral panel was done, it was negative, and the patient again was tested with another PCR. The fourth PCR was positive in this patient, so was diagnosed as COVID-19 eventually. The other two patients that I'm going to present now, they presented during the COVID period. The first one was a known lymphoma. He presented with fever, shortness of breath, and cough. He had a CT because he's lymphoma, and we found on the CT these mixed density or areas of consolidative opacity scattered peripheral and central with surrounding halo. And again, you're going to report these as likely related to infectious etiology. We should consider COVID in the differentials. He was tested twice with PCR and was negative. So eventually he had bronchoscopy and BAL, and that weird organism was cultured, is even very difficult to pronounce. He was treated with antibiotics and recovered completely. So this was not COVID. Another patient who presented during the COVID era, 83, elderly male with shortness of breath, cough, and of course he got a chest X-ray and PCR testing. Because of his presentation, his PCR turned negative, and the chest X-ray shows multiple pulmonary nodules, eventually suggested metastasis, and was proven metastasis. So the lesson learned from these patients is imaging is indicated in patients with respiratory symptoms if PCR is unavailable or is negative, and mainly to exclude alternative diagnosis or might be a false negative PCR. And that not every opacity on chest X-ray or CT is COVID-19 related. CT is very sensitive, but is non-specific. And from that, I will take you through the indications of imaging in COVID-19. And we, most of us, I think, we follow the consensus statement made by the Fleischner Society on the indications of imaging, where they divided patients into multiple scenarios and extrapolated the indications from these. And I made it as a summary in this slide. First, starting with the no imaging is required in asymptomatic patients with a positive PCR test, or patients with mild symptoms and no risk factors for disease progression. And those patients are mainly the patients who are kept on home isolation just because of a positive PCR test. Imaging is indicated with a chest X-ray or CT in patients with moderate to severe respiratory disease. And we basically start with a chest X-ray in all of these patients. Patients presenting with mild, moderate, or severe symptoms and have risk factors for disease progression, and mainly to assess for disease severity. We start usually with a chest X-ray and CT if needed. Mild, moderate, or severe symptoms, but with worsening respiratory status. And in these cases, you mainly want to exclude complications or progression of infections. Again, serial chest X-rays or CT if needed. And in which subset of cases you would preferably need CT? Those cases with moderate to severe symptoms, but PCR is unavailable or is negative. So it might be falsely negative, as I showed you, or to exclude alternative diagnosis. Patients with functional impairment or hypoxemia after recovering from COVID-19. What were the other recommendations on that paper? That daily chest X-ray is not indicated in stable intubated patients with COVID-19. That PCR testing is suggested in patients with incidental findings suspicious for COVID-19 on imaging. And that the decision must be weighed against availability of PPE, availability of testing, and the urgent need for a diagnosis, especially in the crowded hospitals. From that, I'm going to move into the complications of COVID. What are the complications reported in COVID-19? First, those complications were unclear if they're related to COVID-19 directly or they're found incidentally in those patients. The common complications were thrombosis, whether venous or arterial, like stroke, DVT, PE, pulmonary embolism, pneumothorax, pneumomediastinum, acute cardiac injury, neurologic complications, and abdominal complications. This is an example of a pneumomediastinum in a COVID-19, pretty extensive disease in the lungs. Intubated patient in the ICU developed pneumothorax. And most of these, pneumomediastinum. Most of these pneumomediastinum are a result of intubation in those patients with stiff lungs. Here's another interesting case that came to us. This is a young female presented with fever and shortness of breath. She tested positive for COVID. Pretty normal respiratory parameters. She presented with a severe left flank pain. They requested a KUB before discharge because they were planning to discharge the patient. She was fine apart from her severe left flank pain. We did the KUB study and it was negative. So they contacted me the next day. They said they did not discharge the patient, but she still has that severe flank pain that they could not explain. So I looked at the lung bases in those images, and you see these peripheral areas of consolidation with reversed halo sign and central areas of ground glass opacities with that bubbly appearance. And I said, just bring the patient for a pulmonary angiogram. We did CT pulmonary angiogram, and you could see that big clots in the lower lobe segmental and subsegmental branches, and that was proven to be pulmonary embolism in this patient. Surprisingly, her D-dimer on admission was high, but it was dropping down to 2.7 at the time of when we did the CT pulmonary angio. She was on prophylactic enoxaparin from the day of admission. So what about pulmonary embolism in COVID-19? The incidence of PE in these patients is considered high compared to the normal population. It ranges in the literature between 28 and 30%. That prophylactic anticoagulation does not prevent the occurrence of PE. D-dimer is not a sensitive indicator in these patients because it might be elevated in patients with COVID-19. Remember, those patients are already hypocoagulable. That sudden progression on chest X-ray has no correlation with increased risk of PE. We all think that because of the sudden deterioration, because of the admission into the ICUs, those patients are at more increased risk. They found no correlation between the progression on chest X-ray and the number of PE patients. So what are the risks then? There was higher risk in critical ICU patients and patients specifically on mechanical ventilations. The indications of doing CTPA in these patients was very variable between studies. And I personally think that there is no specific indications, but we have to wait based on the patient's presentation. Some of the indications they mentioned is the sudden deterioration in respiratory status. So patients developing sudden hypoxia, increased oxygen demands, tachycardia, or when findings on the chest X-ray or CT cannot explain the severity of the respiratory failure, increasing D-dimer or persistently high levels of D-dimers, and higher risk in patients with DVT. So my advice is be more liberal in doing CTPAs in COVID-19 patients. We do already do a lot of CTs in regular patients, so why not in COVID-19? What are the debates that we had during the COVID-19 period, and how did we deal with them? So I'm going to go through a few debates. The first one was CT for the diagnosis and triaging of COVID-19. Can CT and chest X-ray scoring help in triaging patients and predicts patients' outcome? Well, there were many publications talking about CT scoring, chest X-ray scoring, whether taking whole lung in consideration or dividing the lungs into lobes, segments, and zones, and summing up the scores from different lobes and come up with a eventually percentage of lung involvement and correlating that with severity of the lung changes, the patient's outcome. They also used AI and quantitative CT estimations. Again, calculating the number of involved segments of the CT and coming up with different scores and correlating them with outcome and prognosis of the patients. What I've learned from these publications that there was good correlation between CT and chest X-ray scoring with disease severity and patient outcome in terms of who would require hospitalization or intubations. However, the limitations in those studies that in most studies scores were measured on the initial CT, regardless of the time interval between the initial CT and the exposure, as well as the symptoms. And we all know that COVID patients have variable presentations and progression on the chest X-ray. So the initial CT might look normal. However, on the next day or 2 days after, the patient would have progression on their imaging. Other limitations were that CT was performed in every patient, and that was mainly in the era where there are limited PCR testing. There was no histologic correlation or confirmations. All studies suffered from small sample size, and they're all retrospective studies, so there were clinical and lab parameters which they more depended on and correlated that with the CT findings. And I'm going to show you examples of 2 patients here. These patients I showed before. A patient, the first patient on the right, had pretty extensive changes on the CT. However, he was only admitted to the isolation and oxygen mask and recovered. So if we depend only on the CT, it would be very difficult to judge which patients or predict which patients would have a worse outcome than the other. In comparison to the other patient who have milder changes on the CT but was admitted to the ICU eventually. Here's an example of rapid progression on chest X-ray. If we measure the scoring on the first X-ray, patient progressed rapidly during 1 week, and you could tell that the scoring would be different between the first X-ray and the last X-ray during only over a period of 1 week. So it was the next debate. The next question was raised to us, actually was, is CT chest indicated before emergency surgery? And the request was based on many facts: that the PCR results might take longer than 24 hours to appear, that surgery carries a higher post-operative morbidity and mortality in COVID-19 patients in terms of ICU admissions, prolonged hospitalization and progression to ARDS in these patients. That some surgical cases can be managed conservatively, like acute cholecystitis, appendicitis, if the patient turns to be COVID-19. That the risk of intubation and laparoscopic procedures is high because they're aerosol generating procedures. And I only found few publications in regard to that issue. So China and England advocate for doing CT chest before emergency surgery. In any patients presenting with acute abdomen, you're going to have a CT abdomen. So with it, they would request the CT chest to see if there's changes of COVID-19. However, that should not be interpreted as completely negative, because we know that CTs might be negative in those patients. Now, I don't think that this is a problem, since we have the rapid testing for PCR. We did not perform CT chest for emergency surgery. We asked them to go with the clinical suspicion if it's high or not, because CT might still be negative in those patients in early presentations. So we did not do it before, and we don't do it now since we have a rapid testing for PCR. Before elective surgery is of no question. We do PCR for all patients admitted for surgery. The next question was when to do CT pulmonary angiogram, and we already discussed that. The next debate was, is PCR testing necessary before any procedures done in the radiology department, including lung biopsies? And what is the validity period? So I found no solid recommendations in the literature. However, it depends on the hospital policy and the availability of PPEs and testing. We in our hospital test all patients before admission and before procedures in these patients who require day surgery admission. What about imaging in recovered COVID-19? We know that COVID-19 can go through progression of findings and then through recovery period. So I'm going to focus mainly on the recovery period, where you're going to see decrease in the densities of ground glass opacities and consolidation, decrease in the size of these opacities. You're going to start seeing atoll sign and fibrosis in terms of distortion and traction bronchiectasis. Well, we have to know that CT abnormalities can take longer to resolve than PCR. And in patients with COVID-19, PCR might become even negative before, and CT would show still persistent or resolving changes.
Doctor, I'm sorry, you have 2 minutes to go.
Okay. I'm going to show you 3 patients with, in this scenario. This is a patient who presented with a positive swab. 3 weeks later, I don't have any x-rays in between, but 3 weeks later, you see these coarse reticular densities in both lungs, had a CT thereafter, and you see these coarse reticular densities resolving ground glass opacities, an element of distortion, traction bronchiectasis, Another patient who was tested positive, admitted to the ICU. These two x-rays are few days apart. He had changes in the lungs, almost diffuse consolidations in both lungs. He had a CT 2 months later because of persistent symptoms. By the way, those two patients were discharged and they came eventually later with persistent shortness of breath and other symptoms. You can see on the CT, again, distortion, areas of coarse reticulation, traction bronchiectasis, and an element of fibrosis. Another patient who had COVID-19 changes on presentation. Almost more than a month later, he had persistent fibrotic changes in right mid-lung. He had a CT 1 week prior to the last CT, and you see again fibrotic changes, traction bronchiectasis, reticular densities, and an element of fibrosis. These patients were all in the period of 2 months in the recovery period. So what do we know about post-COVID changes? We know from previous literature that 30% of people with SARS or MERS-CoV had persisting lung abnormalities after their acute illness. There is a very limited evidence on the follow-up protocols and management of COVID-19 patients. We need more studies, we need longer periods of follow-up to see. However, what we know clinically that 80% of patients experience prolonged illness after COVID-19, and I found that this is the largest study with the largest sample size made in China that considered patients' pulmonary function test and CT imaging up to 3 months after recovery from COVID-19, and they reported these changes. We don't know what would happen to these changes that we see on the CT. Would they recover? Would they still persist, or would they progress into more fibrosis in the future? Clinically, many patients would recover spontaneously over time with just supportive measures. The role of steroids is unknown. I didn't find any publication that supports the use of steroids in these patients, but we need more studies for this. So in summary, imaging COVID-19 should be reserved for certain indications to minimize disease transmission and false interpretation. That findings on CT are not specific and overlap with other viral infections, including MERS-CoV and H1N1, as well with other non-infectious diseases. That the incidence of PE is high in COVID-19 and there are no specific criteria to predict who needs CTPA. That is, more evidence is needed to evaluate the outcome of COVID-19 on imaging and correlate them with the clinical parameters. Thank you very much.
Thank you very much, Dr. Nasreen, for the amazing lecture. We have 2 questions for you. So one, would you advise CT to assess for fibrosis in those patients?
So a lot of, there's no solid recommendations for any imaging follow-up in COVID-19 patients until now in the literature. But if the patients, the recommendations from the Fleischner Society that they recommended CT in patients who have persistent symptoms post-COVID-19. And in my opinion, I would take it according to the clinical presentations of the patients, if they would require imaging or not. If they can recover on supportive measures, then probably imaging is not needed.
Okay, great. So one more question from the attendee. So is the CT scoring for those patients?
Well, as I showed you in the slides, we don't do CT scoring. Again, I've asked clinicians many times, they don't depend on our scoring. They depend mainly on the clinical parameters of the patients and the lab results. And they don't even look, the only thing that matters to them is the rapid progression of findings on CTs or chest x-rays. Otherwise, they don't take CT scoring in consideration. I don't know if the others have other experiences with that.
Okay, thank you very much. I think we are ready for the next speaker.
Okay, and it's my pleasure to introduce the next speaker, Dr. Hani Assalam, consultant radiologist in Qatif Central Hospital. Saudi Arabia, subspecialized on thoracic imaging from McGill University. And what makes him special that he's a former PhD editor in the period 2008 to 2012 with over than 1,000 contributions. Today, he will be sharing with us a few of his best international contributions.
Assalamu alaikum. Good afternoon, everybody. Today I will present a few cases from my fellowship. I hope they are interesting for you and it will be a fruitful presentation. So I divide the presentation into 4 parts, depending on the case's causative organism as well as the disease process caused by this organisms. So starting with the first case, this is a 70-year-old female patient presented with dyspnea. So frontal and lateral chest radiograph was performed, which demonstrate an L definition of the cardiac border, especially at the right cardiac border. And if you concentrate on the lateral radiograph, you will see a linear opacity in the expected location of the right middle lobe and lingula, which could represent either subsegmental atelectasis or scarring. So CT was performed, which demonstrate 3 embed opacities and traction bronchiectasis, as well as a scarring in both the right middle lobe and lingula. So the constellation of these findings, as well as the patient demographics, is highly suggestive of the clinical diagnosis of Lady-Windermere syndrome. So Lady-Windermere syndrome is a disease caused by Mycobacterium avium complex, and it is seen typically in elderly women who have the habit of suppressing the normal cough reflex. So Mycobacterium avium complex is one of the non-tuberculous mycobacteria, and it is considered the most common cause of the disease process, and it is primarily a pulmonary pathogen. However, it has also associated with other part of the body infection. The second case is a 70-year-old male patient who was a smoker with chronic cough and dyspnea. So these are the CT scan of the patient, which demonstrate a nodule on the right upper lobe. The nodule demonstrates a central cavitation, and it is associated with scarring and traction bronchiectasis. So these findings are seen in the background of severe confluent centrilobular emphysema. Because he is high risk, biopsy was suggested for this lesion to exclude the possibility of malignancy. So the culture came positive with Mycobacterium zenubi. Mycobacterium zenubi is a part of the non-tuberculous mycobacterial infection as well. It is uncommon in most of the region and has been reported as the leading cause of non-tuberculous mycobacteria pulmonary disease in Europe and Canada. And it usually occurs in patients with a pre-existing chronic lung disease, particularly COPD as our patient, as well as has been reported in patients with HIV and AIDS. It has 3 radiological appearance: the fibrocavitary, in which the main finding is a mass or a nodule with cavitation, as our case. And the other radiological appearances are nodular, that usually associated with the bronchiectasis. So some say it is nodular bronchiectatic. And the least common radiological appearance is the infiltrative type. So the fibrocavitary and nodular bronchiectatic are the most commonly encountered in clinical practice. The fibrocavitary is more common in male patient who has emphysema as our case, and usually those patient has a positive acid-fast bacilli smear. They have more constitutional symptoms that will result in early initiation of the therapy. Whereas the nodular bronchiectatic type is seen more commonly in females that are non-smoker. The acid-fast bacilli is usually negative in these cases, and they have prior Mycobacterium avium complex infection, and most of the time they have also concomitant Pseudomonas aeruginosa infection. So by this, I covered the first part of the presentation. The second part will start with the case number 3. This is a 50-year-old male patient with a history of 2 years post-stem cell transplant, have decreasing DLCO in the past 4 months. So these are selected images of the CT scan of the chest, which demonstrate bilateral, well-defined nodules. These nodules has characteristic surrounded by ground glass appearance, and the dominant nodular opacity is seen in the right upper lobe, as seen in these coronal images. And as we see, there is associated surrounded by areas of ground glass. So these areas of ground glass is called CT halo sign, and it is most of the time represent areas of hemorrhage, and it is typically has been described in patients with angioinvasive aspergillosis. These are the extensive causes of CT halo sign. Mainly they are infectious process, and most of the time they are related to fungal infection, and pulmonary aspergillosis is in the top of the list. So the final diagnosis of angioinvasive aspergillosis was made, and this is considered the most severe and aggressive form of aspergillus infection. It is a life-threatening condition, and it required prompt treatment. It only occurs in profoundly immune-compromised patients, those with prolonged high dose of corticosteroid, those who are neutropenic, graft versus host disease after allogenic bone marrow transplant, as well as those with end-stage AIDS. Next case is a 50-year-old female non-case of asthma. And these are the frontal and lateral radiograph of the patient, and demonstrate nodules on the left upper lung zones. We have 2 nodules. The one that is larger is more anterior, and this is really appreciated on the lateral radiograph, whereas the smaller one appear more posterior, and it's not really projected well on the lateral radiograph. This patient has a previous X-ray from 1 year back that demonstrate no nodule. So the larger nodule was not present at that time, and there is a faint nodular opacity at the location of the small nodule. Fortunately, we have an oblique radiograph that demonstrates the nodule for better extent. The CT from 2014 demonstrates that small nodule is very well defined, and it have this characteristic crescent air. So make aspergilloma is high likely. This is at the presentation now that demonstrate that nodule has already grown up, and it is demonstrate the same finding, and the smaller one also have similar characteristic. So biopsy was done, and aspergillus was isolated. So the sign is called air crescent sign, and it has been described with invasive aspergillosis and semi-invasive aspergillosis and aspergilloma, and other processes that will cause pulmonary necrosis. It usually heralds recovery and is the result of increased granulocyte activity. So the causes of air crescent sign in the lung, most commonly, as I've mentioned, aspergilloma and angioinvasive aspergillosis. Hydatid cyst is a culprit, and there are other rare causes. So aspergillosis can present in 4 clinical presentation. The first is non-invasive, whereas a fastball will occupy a pre-existing cavity. A semi-invasive, this is usually more chronic and indolent, and cavity formation will result in aspergilloma. And usually patient has depressed immunity. Those is invasive aspergillosis, as we have mentioned, is the most aggressive and severe form, and usually happen in patients with severe immune compromism. And allergic bronchopulmonary aspergillosis, this usually happen with patients with hypersensitivity reaction, usually asthmatic, and cystic fibrosis patients. So by this, I covered the second part of the presentation. The third part, the first case is 28-year-old female who is a smoker with on and off chest pain. This is quite interesting case. A young patient that presented with this finding. So the CT scan demonstrate right upper lobe ill-defined, irregular, infiltrative process associated with smooth interlobular septal thickening and enlarged ipsilateral hilar lymph nodes. So these are the reformatted coronal images. Again, demonstrate for a better extent that ill-defined, irregular, consolidative or infiltrative process associated, as I mentioned, smooth interlobular septal thickening and associated enlarged hilar lymphadenopathy. So the patient was reluctant to do biopsy at that time, and in a 10 days time, she presented with acute chest pain. They thought it might develop pulmonary embolism. So we did a pulmonary embolism study, which was negative. However, the right upper lobe infiltrative process has progressed over this period and become more larger and more infiltrating the right upper lobe. Some areas of associated with ground glass opacity. Biopsy done at this time, and it shows histoplasma capsulitum. Patient was started on treatment. This is the initial radiograph, and this is post-treatment radiograph, demonstrate response to treatment. The next case is a 70-year-old male patient, non-case of Wegener granulomatosis and immunosuppressive therapy. He presented with low back pain and abnormal chest radiograph. So these are frontal and lateral chest radiograph of the patient, which demonstrate bilateral nodular opacities. The larger is in the right middle lung zones, which is really appreciated on the lateral radiograph to appear in the superior segment of the right lower lobe. And characteristically, there is a central calcification within this mass or nodule. So CT scan was performed for this patient, which demonstrate this well-defined nodular opacity with central calcification and the small air locule within it. This is the coronal reformat, again, demonstrate this nodule for better extent. The patient also has several other nodules that most are calcified, as well as cluster of non-calcified small nodules. So giving the characteristic appearance, this is, and the exposure history, this is a histoplasmoma. Is a specific kind of nodule secondary to granulomatous reaction to histoplasmosis infection. And it gives a pathognomonic target sign appearance. Although classically histoplasmoma was conceived to be a solitary lesion, there are several reports of multiple histoplasmomas in single patient, and they vary in size and they may grow in size and even maybe more than 3 centimeters in size. The last case from the same spectrum is a 50-year-old male patient presented with a chest pain. And the frontal and lateral radiograph demonstrate left middle lung zone, peripheral nodular opacity. And that opacity is not very well projected over the lateral radiograph, make it more likely is hiding within the hilar shadow. So this is the CT scan of the same patient, which demonstrates nodular opacity is really well defined, but has slightly irregular border with minimal rent of a ground glass. And giving a high risk patient, we thought this probably represent a growing malignancy, especially in the presence of associated enlarged hilar lymph nodes. So PET scan was performed as a part of the staging process, and that nodule demonstrate an avid or high uptake of FDG, as well as high uptake in the associated hilar and mediastinal lymph nodes. Biopsy was performed for this nodule, and again, it grows histoplasma capsulitum. Patient was started on treatment, and this is the follow-up X-ray after treatment. So histoplasmosis is a pulmonary infection with the organism Histoplasma capsulitum. This is an endemic in the Central America state of El Salvador, but it's found also widely in other parts of North and South America. It has a variable clinical and radiological presentation, as we demonstrated in these 3 cases. It depends mainly on the state of the infection and the host comorbidities and immune status. The presentation of this disease could be an acute, usually 1 week of exposure, and patient usually present with cough and hemoptysis if it is involving the bronchioles, and as well as dysphagia if this involving the esophagus. The subacute presentation usually those patients present with the small calcified nodules associated usually with hilar and mediastinal lymph nodes that tend to calcify. The chronic presentation is seen mainly with patients with COPD, and usually the symptom persists more than 3 months. And the rarely disseminated progressive form that usually occur in patients with immune deficient patient, such as AIDS patient or those with high corticosteroid. And this usually very severe and fatal. By this, I covered the 3rd part of the presentation. The last part, this is a 45-year-old patient that presented with dyspnea and non-productive cough. And he gave a history of previous recurrent chest infections. So this was the frontal radiograph from September 2015. This was presented, was done outside our institute, and it demonstrates right upper lung zones infiltrative patchy opacity. The patient was started on antibiotic at that time, and he did not respond very well. So this is a follow-up X-ray from 1 month apart, and demonstrate that the right upper lung zone opacity is more or less the same or slightly getting worse. However, the left lung, now there is a newly developed patchy nodular opacity, as well as the perihilar region become more prominent at this radiograph. So he was referred to our hospital for investigation as He was not responding to the usual antibiotics. And at the presentation, this was his frontal and lateral radiograph that demonstrate now severe progression of the disease that become more diffuse, involve the lungs. So this is from the period of almost 3 months. So we decided to do a CT at that time, and CT scan demonstrate a patchy, consolidative, irregular process, and it demonstrates incidental finding of anterior mediastinal mass. These are the coronary formatted images for the patient, which demonstrate again very extensive bilateral, predominantly peribronchovascular, consolidative patchy process, as well as the incidental finding of anterior mediastinal mass.
Dr. Hani, you have 2 minutes.
Okay, I'm finishing. Then these are the beta scan, which demonstrate avid FDG uptake of these infiltrative process and no much uptake of this anterior mediastinal mass. So the plan was to do biopsy of this anterior mediastinal mass, bronchoalveolar lavage, and bronchoscopic biopsy of these infiltrative bilateral processes. So the final diagnosis was Good syndrome, as this anterior mediastinal mass turned to be a thymoma. And this is a rare paraneoplastic syndrome causing both B cell and T cell immune mediated defect. And those patients are highly susceptible to recurrent bacterial, viral, as well as fungal infection, and as well as autoimmune processes. The lung infiltrative process grows pneumocystis jirovecii pneumonia, which is a yeast-like fungus of the genus Pneumocystis, and this is the most common opportunistic infection in patients with AIDS. And it is virtually never present in immunocompetent patient, and the diagnosis is often confirmed with the bronchoalveolar lavage with high sensitivity. So the patient was started on treatment and he was improving over time. This is the last case, which is a companion case for the same disease process, but with different presentation in an HIV patient. So this patient presented with acute shortness of breath over a period of 12 hours, and this is the left radiograph was at the presentation, and in the follow-up radiograph, he developed diffuse faint opacification of both lungs. And don't be distracted by the pleural calcification and plaques related to asbestos-related lung disease, as we see in CT. So the CT scan demonstrate diffuse ground glass. Characteristically, it is central, and it is associated with a smooth interlobular septal thickening, giving the crazy paving pattern. So the first case is a PCP with atypical finding that usually present with consolidation, nodules, lymphadenopathy, and pleural effusion. Whereas the second case is the pneumocystis pneumonia with the typical finding of ground glass opacity, reticular pattern giving the crazy paving. Some of the patients report to have pneumatoceles in up to 30%. And pleural effusion and lymph node enlargement is considered very rare, and it is considered an atypical finding for pneumocystis pneumonia. So by this, I finished the presentation. Thank you.
Thank you very much, Dr. Hani. Wonderful collection and a great presentation. There was one question from the attendees. What is the DCLO mentioned at the beginning of the lecture? I think one of the attendees are asking.
So this is called, it is diffuse lung for carbon monoxide, and it is used as an indicator for release of the oxygen from the alveoli to the blood.
Mm-hmm.
It is part of the lung function test.
Okay, thank you. Any more questions? I don't think we have any more questions for Dr. Hani. Thank you very much. We have two more questions from the attendees for Dr. Nisreen regarding the previous lecture of COVID, imaging of COVID. The first one is, what is the incidence of ILD, interstitial lung disease, post-COVID? Dr. Nisreen.
So this is a very difficult question to answer because we have, as I said before, publications are very rare and we need time for these cases to emerge so we can have a real incidence of ILD in these patients. Based on the previous publications, the very small publications, there is a high rate of findings on imaging. I wouldn't say ILD, but findings on imaging, but we don't know if these findings would progress into persistent ILDs versus recovery. We don't know yet. So we don't know really in incidence, that's the answer.
Would you say that in the progression of COP, so COVID patients usually present with findings of COP, is the ILD the same incidence of COP progressing into ILD, or we still don't know?
So what we've seen, and I would like to for others to contribute what their experience is. What we've seen until now from the cases, at least the cases I've seen, they look like COVID. Those ground glass densities would eventually disappear. They would have an element of fibrosis, traction bronchiectasis. It's something in between COP and NSIP changes. But we don't know, what we don't know is if those changes would recover or would progress eventually. I don't know if any other radiologists have any other experiences they can share with us.
I can share something not related to COVID, but I think we have strong evidence that was reflected back in a paper in Radiographics regarding the evolution of organizing pneumonia into different stages, including cellular, ending up with a fibrosis. And I think we do know that we see organizing pneumonia in different pathologies. So I wouldn't be surprised to see that evolution of an organizing pneumonia into fibrosis. And I would invite people actually to go back to that paper. I think it was published in Radiographics in 2012 or 2013. A great paper about the various evolutions of organizing pneumonia, cellular and fibrosis.
The second question is for Dr. Nisreen. Would you recommend CT pulmonary angiogram for any patient showing worsening symptoms?
So again, as I said, it's easier to recommend CT pulmonary angio in non-COVID patients than COVID patients. We're very liberal in doing CT pulmonary angios in non-COVID patients, because there is nothing really solid about when do we suspect PE in these patients. Their clinical presentation is very variable, their progression is very variable. So really it has to be taken into many parameters and clinical context, whether to decide, because we know that patients do progress related only to COVID changes and is not related to PE. And many countries have many different protocols in when to do CTs. Like in some regions, they would do CT for every patient who is admitted to the ICU. And that's why their number of PEs are high. Even they would pick up patients who have incidental findings of PE while those patients are already on anticoagulations. So the matter that finding PEs in these patients might not really matter because are already on anticoagulations. So clear, solid recommendations based on just clinical deterioration. It has to go patient based, patient by patient, and they have to take in considerations the other lab findings and the other clinical parameters.
Okay, thank you. Dr. Oduni, do we have time for one more question or? Okay, so the last question is for Dr. Nasreen. Would you consider the minor fibrotic changes in case of advanced COVID-19 as just fibrotic changes or as lung fibrosis?
I did not understand the question.
So in advanced COVID-19 infection, I think severe infection, would you consider the residual changes as fibrotic changes, or would you label as fibrosis?
Again, this question is being repeated many times, but once you see fibrosis, reticulation, pleural retraction, you would call them fibrosis, right? Even we see this even during the COVID progression, even before recovery, I mean, before discharging the patient, you would see that these type of resolution and fibrotic changes, we see them in a lot of patients. Whether these fibrosis will persist or would recover, I don't know. But we do call them fibrosis eventually, once you have lung distortions, traction bronchiectasis, and these findings.
Yes. Okay, thank you very much.
Okay, so we'll move on, and I'm happy to introduce the next speaker, Dr. Ibrahim Al-Mugi. He's a consultant radiologist and regional medical director of imaging in. He has trained in Egypt and United States Stanford Medical Center in body and cardiology. He's presenting a presentation about artificial intelligence, specifically in pulmonary infection. And I'm excited also that the group is arranging for a special meeting about radiology later on.
Thank you, Dr. Daniam. Thank you all, the panelists, for this wonderful presentation we had. Thanks, of course, for the attendees. Today, I will go quickly on AI and pulmonary infection specifically, but I will mention some stuff for AI in medicine as well. So I will start with identification. I will not spend a lot of time over here, but we will keep all the information about AI itself to the next webinar and about AI in cardiothoracic as all. But artificial intelligence is not something new. Artificial intelligence is something we practice or we have every day. And the pure definition of artificial intelligence is something can simulate a human intelligence. It can be a very simple thing like a calculator. You need, you can multiply 2 by 3, but you can also use your cell phone calculator or whatever calculator you have. And this is considered as an artificial intelligence. And it's meant not to replace you, but it's meant to help you to be more productive. There's some subsidiaries from artificial intelligence, which we call machine learning, and the most complicated one, which is called deep learning. Artificial intelligence is not only in diagnosis. Artificial intelligence actually have more parts outside the diagnosis rather than diagnosis right now. It's more towards patient records, how protocoling, by intelligent protocoling, scheduling of the patients, and a huge part in the acquisition. We see it, and we'll talk about it right now, in enhancing the image quality and reducing the radiation dose and planning the same cuts every time on the same. So you see, if you are comparing on over time, you can see the same cut every time in the same place. And of course, the post-processing, which consumed some of our time. If you wanna, we're talking about quantification of COVID burden on the lung today. As Dr. Nissim mentioned, this is done by AI. So you spend more time focusing on your diagnosis rather than spending more time in doing some other stuff. So I will start with the first one, which is something called true fidelity. True fidelity is deep learning, so it's one of the most complicated artificial intelligence algorithms, where we try to denoise the CT images. And just before going into that, let's see how it was before. So in the images initially got with CT, we were using what we called filter back projection. At filter back projection, as you see, the images are sharp, but they are noisy. They are so noisy. And the dose, radiation dose was high. Then the era came of iterative reconstruction. And the iterative reconstruction, which is called Azure, Sapphire, a lot of names across vendors. This was to reduce the dose and reducing the dose by reducing the noise. And this was just a reconstruction algorithm to do this. Now with introduction of the deep learning as artificial intelligence part or component into that, we can maintain the image quality, the sharpness, the details of the old filter back projection with the low dose and the better quality of even much better than iterative reconstruction. And this actually can do a couple of things for us. The first one is the dose reduction. So if you see these images, this was done by iterative reconstruction, which is the most currently used technology, and that one was used by true fidelity. You can see and appreciate, of course, the more details. When you're talking about pulmonary nodule and you want to try to differentiate if it's an infection or neoplastic, you usually look for the borders, for the parenchyma surrounding, looking for any abnormalities into there to prefer infection rather than neoplastic. But actually, with a little bit of smoothing of the image quality, you cannot have that. And the other one, which is important, we usually don't see the images at very thin slice thicknesses. So we acquire at 0.6, but we usually tend more to see the images at 1.2 millimeter because image 0.6 millimeter are so noisy. So in that case, for example, it's a COVID patient, and you can see the pneumonia, some of the granuloglobulopathies, and the dose is very low. So this one was one of the benefits of using these artificial intelligence in reducing the patient dose. And actually, it can be reduced more because it's acquired at 100 kV, which is recommended not to miss a COVID, a small or minor or faint ground glass, but this was based on these technologies. And with the new technology, we believe it will be able, you will be able to reduce more, and you will still have the sharpness and diagnosis you want. This is another patient of COVID, so the same patient we're talking about with consultations and the difference between the image is here. Another patient, again, the details are very sharp within the details are here very sharp, and you can see really appreciate the details in the images. And this is another example for 0.6 millimeter. We usually don't see this, and actually you don't need to do this every time. You don't need to. Otherwise, you will have a plenty of images to review. But if you have a problem and you wanted to see more details, the thin slices, previously the images were noisy, the image was hazy, you cannot see the details well. But with deep learning and artificial intelligence, this is something you can have. So the first part we talked today about how AI can help us into increasing our precision, how we increase our confidence, and of course reducing also the radiation dose for the patients, which is very helpful, of course, in follow-up in oncology cases. The other one is an example. I just today have couple of examples for you. The other example is for diagnosis. So this is a tool which work on CT, in X-ray, chest X-ray for diagnosis. See, for example, we have here an X-ray image. I think we may be looking for pathology, and in the areas where there's an overlap, this sometimes be a problem. So we have something over here, and let's see how the reaction of the AI. Yep, the AI captured it. So it's an AI algorithm, artificial intelligence algorithm, again using the deep learning. And this is where the image is going to a PC or a server into your hospital, and the images will be processed in few seconds, and it will come back to your PACS. You will have the original image, and you will have an image with a highlight or ROI, and it will indicate also the abnormality score. So from this image, the artificial intelligence think there is an abnormality over here, and the possibility of this abnormality is 92% regarding its algorithm. Another case over here, and you can see, okay, the lung, okay, but here another one. We have two overlap opacities over here, which is the liver and the right diaphragmatic copula, and the costophrenic angle is free, but there is another opacity over here. And let's see, yep, again, where the AI captured it. And actually, it was detected only by 6 of 10 radiologists when they saw the images. And this is abnormality score. This is abnormality score. It's less than 92. Still, it indicates you have a problem over here. Please go and review it. It's a consolidation on this area. Another one is this maybe looks like normal, and actually it's hardly. Yep, the image is a little bit soft. Maybe if we harden it a little bit, we can see some findings. But looks like it's normal case, and again the X-ray have been. The AI shown there is abnormality over here, and all of those cases have been confirmed, by the way, by CT. So it's pneumonia consolidation in the left, faint consolidation in the left loop, and this was not detected by those 10 radiologists. And you see the abnormality score is low, but there is something to mention for you. Please check for this. And another case with COVID, we can see the scapula, we can see an opacity over here, and again, there's an abnormality score over it. Another case with multiple opacities. Again, there's another case over here with most probably this patient was in ICU, and multiple opacities in both lungs, and it's almost highlighted all of those opacities. Another case of COVID, we know COVID is the most interesting thing right now, and this is one of the milestones for AI, because we hadn't seen a lot of cases coming to the hospital at the same time as we had seen now with this pandemic. It was something new for all of us. We have even the busy hospital who are doing 80 and 100 X-rays per day on one system. They had hugely increase in the number of the cases. So and the stuff is the same. So they needed some tools to increase their productivity. And actually, in that, what the AI is trying to do is to help you, rather than spending 1 hour in diagnosing 10 patients, to spend this hour in diagnosing 20 or 30 patients. So by highlighting the abnormality, you save time. And of course, it will increase your sensitivity as well. Another case of COVID with the CT findings, even if it's faint ground-glass opacities, it's appreciated over here in especially on the left lung, on the X-ray, and again, the score is high. The probability of having a pathology over here is high. So this is one of the important things in that in any AI technology you are looking or you're using. It's sensitivity and specificity, and usually you will have you will practice a little bit on your system, and then you will know your system more. will know your algorithm or your software you are using. And once you do that, you will have a trust in your system. And this is a cutoff value you can modify. So for example, if I am saying, okay, don't mention any pathology if you feel it doesn't match 45% of the criteria you already have. And this is, of course, will increase the specificity, but will decrease the sensitivity. But if you wanted to have more sensitivity, you can go for 0.15. So if there's a criteria in the images that can match the pathologies you trained on as an AI, please mention them. If they are more than 15%, specificity will go low, but sensitivity will, of course. The other one, of course, which is very important to the area and to the curve. And as I was talking, one of the most important is the number and the variety of the cases the algorithm have been trained on, the software have been trained on. So those, for example, data, this one is not only for pneumonia, it detects consolidation, atelectasis, calcification, pneumothorax, mediastinal, cardiomegaly. It have fibrosis, nodules, and we have a couple of good cases of nodules that had been detected overlapping rib shadow or scapula, and it was very difficult to be detected by eyes, and the AI was capable of mentioning those. So with an increased number of cases, you train your algorithm. So in that one, it was 3,000. By October, that software had been trained on 3,000. Now it had been trained on 160,000, and we are acquiring a 2.5 million cases to train this software. So it has seen much more images than most of us have been doing. And so there's almost a question: is artificial intelligence is going to replace radiologists? I don't think calculator hadn't been replaced mathematicians, but actually you can look at it as the first generation of the ultrasound, which was the linear ultrasound, you need to take line by line, have been replaced and came with the version we have right now with ultrasound and the probes we have. This hadn't been replaced the radiologists, but the radiologists who stick to the previous version, who have been replaced. So all of us need to start to utilize some part of the AI into our daily practice, because most of the people who actually use the AI believe this AI will not replace the radiologists, but radiologists who are using the AI will replace who don't. And this will be for our next session, when we go deeper into talking about the AI itself, what's the meaning by machine learning and deep learning and neural network, and what's the training and validation data sets. And we will know how our image like this for a cat had changed our career. With that, it was just a simple and fast introduction to the AI and how can AI help us in future of our career. And I would be happy to hear any questions.
Thank you very much, Dr. Ibrahim. Amazing introduction. And the question we have is actually related to the last part of your lecture. One of the attendees asking, how do you think artificial intelligence will affect the future of the radiologists, especially on career opportunities?
Yeah, so I answered. So we expect radiologists who will use AI will be replacing the radiologists who are not using the AI. And honestly, I have been working for the last couple of years in almost covering 20 countries. I hadn't visited any of those countries without a shortage in radiologists. Even highly populated countries like Pakistan, where there's a 200 million population, a lot of radiologists, but there's not enough. Every country I go, our colleagues over there are asking me, do you know radiologists to work? And everywhere in US, the salaries of radiologists in US had been increased tremendously in the last few years. And this is because the shortage of radiologists, because the scans and the clinicians are needing us more. The technology are evolving so much. we need more radiologists to cover those new technologies. So I believe by time we need to be more productive. I don't think we will be replaced by AI, because still you need to validate. Still you need to validate what the AI or any artificial intelligence come to you with the answer. You need to validate this is yes or no.
Thank you very much. Ready
Thank you.
for Donia.
Thank you.
Okay, I was supposed to present Dr. François Fontenot, a very special guest from France, but unfortunately, we had a short notice of his talk cancellation. But his talk will be recorded for viewing later on. And I'll take this opportunity to announce that the lectures in this symposium will be recorded in the RSSA website for viewing later. With that, I will move with the next speaker. So the final talk is presented by my dear colleague, Dr. Masha'al Al-Rajib, who trained in McGill University and completed her fellowship at University of Ottawa, took a master's degree in international healthcare from Frankfurt School of Business and Finance. And Dr. Rajib, I've known her always as a leader. She established the first cardiothoracic radiology fellowship program back in 2016 and was the program director. And she worked as an executive consultant at King Faisal Specialist Hospital in Riyadh. And she has a strong interest in lung cancer, pulmonary hypertension, and congenital heart disease. Today, she will be sharing with us her expert opinion on thoracic intervention.
Thank you, Dunia. I will talk about the value of CT-guided transthoracic needle biopsy in pulmonary infections. And I'm sure that for many of you, this question is not uncommonly raised by other consultants or by colleagues during multidisciplinary teams. And irrespective of whether you are the person who will do the intervention or not, I can assure you that this is a question that many of us will need to answer every now and then. So in the next 15 or 20 minutes, I will try to talk about the infection as a yield from CT-guided transthoracic needle biopsy. I will spend a lot of time talking about adequate sampling because I think it's crucial, and then we'll end up with decision making and treatment, which I think is the hallmark of the value. Before sharing with you images, I would like to share with you the photo of someone probably some of you would know. This is just a teaser, and to share with you my passion in history, including medical history. So we will talk about this guy and a few others who are very much relevant to today's talk. So let's talk about infection as a yield from CT-guided biopsy. This is a case that I came across during my residency training. We ended up hosting an ACR case in point. She was a 19-year-old female patient who presented with pleuritic chest pain. There was a history of recent airplane flight from Vancouver to Montreal of 4 hours, so quite long. And she also gave a history of birth control pills intake. The clinicians were very much concerned about acute pulmonary embolism, and when they did the chest X-ray, they did see a mass-like lesion in the right lower lobe, as you can see. And even though it looked quite awkward for a pulmonary infarction, they still insisted on ruling out that. So a VQ scan was done, and instead of it mismatched, there was a matched perfusion ventilation defect corresponding to a lobulated mass-like consolidation with air bronchograms and CT angiogram sign. The diagnosis, which was coccidiomycosis, was confirmed on a CT-guided biopsy. It was never suspected. As a matter of fact, we were concerned about neoplasm, and that was the main reason we did the CT-guided biopsy. Now, many of you might be familiar with coccidiomycosis in immunocompromised patients, where it usually presents in a disseminated form. However, in areas of high prevalence and in immunocompetent, it could just appear like a mass or nodules. Now, in this case, the diagnosis of infection was not suspected, but many times we do suspect the diagnosis, and we actually go for a CT-guided biopsy to confirm it. For example, this is a patient whom the clinicians were concerned about cancer because he has a history of smoking. He did not have constitutional symptoms and only presented with a bit of cough. But we were more concerned about TB. Sputum analysis and cultures were all negative, and then we ended up doing CT. This case was slightly more sort of complex, and I'll share with you some details later on. But nowadays, I think one of the commonest scenarios where a CT-guided biopsy is being requested for a patient with suspected infection is an immunocompromised. This is a 9-year-old with acute myelocytic leukemia. She presented with febrile neutropenia, started on empirical antifungal treatment for the lesion in the right lung. However, she did not improve after a while, and we were asked to sample. Now, I have to say that this patient was small in size. She also had poor coagulation. She required blood transfusion prior to the procedure. And we did limit the procedure to a fine needle aspiration with 24-gauge needle. But I'm going to talk to you more about the choice of sampling later on. In addition, I'm going to leave you with this question. Once the FNA was done and we did a rapid cytology check, we were able to identify the hyphae, which are very suggestive of aspergillosis. The question is, would you stop there or would you do something else? We're going to answer this later on. So we go back to our trip back in time. The first time biopsy procedure was done was actually in Russia. Late 60s and 1870s. The first person to describe the procedure in the medical dictionary was Ernest Besnier, who was a dermatologist from France. After that, from dermatology to different specialties, biopsy was performed on different organs, including the lungs. And not surprisingly, the first time a biopsy was done, it was done for infection. To confirm the pathogens in patients who were not doing very well. And this was done obviously blindly without image guidance. And the first person to do that was Dr. Leiden from Germany. But the gentleman on the right-hand side is the person behind image-guided transthoracic biopsy. He started the procedure in 1960s, published his work in 1967. He started with fluoroscopy. Some of us were trained to do transthoracic biopsies under fluoroscopy guidance. But shortly after that, CT started to become the imaging modality used for guidance. For interventional radiologists and for some radiologists who do radiofrequency ablation, Dr. Nordenstrom, who is a radiologist from Sweden, is also the man behind radiofrequency. Now, I have to say that most of CT-guided biopsies nowadays are being targeted towards neoplasia. So what is the yield of infection from CT-guided biopsy as a diagnosis? And I would say there are variances in the literature, depending on the cohort and the practice. Meta-analyses have shown that infection is seen as a diagnosis in about 3 to 5%. MD Anderson, which is mainly an oncology center, the infection rate surprisingly is high. However, it actually reflects the fact that many of those patients are immunocompromised and therefore they are prone to infection, but also a more aggressive and vigorous behavior in some of the centers, particularly in the US. High pretest probability in particular has lots of relevance to the yield of infection. And this was particularly seen in lesions that appear as nodules versus consolidations. Fungal infections in particular are easier also to diagnose for different reasons, and we'll talk about that. Now, when I compare that to our cohort from KFSH, and we did collect more than 470 cases over 5 years, infection was actually closer to the meta-analysis, 6%. But I have to say that probably gradually we are increasing in terms of accepting cases for ruling out infection or confirming infection. We cannot talk about pulmonary infections and diagnosis without talking about transbronchial approach. And I think the diagnostic yield in comparison remains superior for percutaneous or CT guided. However, we have to admit that transbronchial on its own, especially when combined with BAL, can improve the yield, especially for diffuse and multifocal disease. Some of the studies have shown superiority of transthoracic needle biopsy, especially when transbronchial or BAL are not being positive. Other transbronchial approaches in specific settings, for example, EBUS, in the presence of mediastinal lymph nodes, like in TB or other infections, in addition to cryobiopsy, which is more recently introduced at KFSH and is not a relatively new technology, which is used for diffuse lung diseases, goes peripheral, and is also been applied for infections. If we compare transthoracic and transbronchial approach, I think it's extremely important not to look at the diagnostic accuracy, but also to look at other determinants. We deal with patients and not just with images. For example, transbronchial approach will invariably need sedation, access of technology in terms of timing, need for OR slots if bronchoscopies are done in OR rooms, which is usually the case, and also in terms of expertise for the specific technology. Cost, surprisingly, is also a sort of a factor that is being overlooked in this part of the world, but I would say that we will be looking more and more into it. And I only came across one study that actually compared transthoracic versus transbronchial, with transbronchial shown to be more cost effective. However, I do have my concerns about the numbers that were chosen. For example, their cost was related also to a higher rate of pneumothorax, which needed intervention in their cohort. So probably more studies are needed. I'll move to the next part, which is adequate sampling. And here I will cover main points. First of all, for many of us, I think there is a sort of a misunderstanding that FNA should be enough when we suspect infection. However, evidence have shown that a core biopsy will improve yield in the majority of cases. Core biopsy can allow a specific diagnosis in 70% of cohorts of patients having infection, and the appearance on histopathology differ depending on the type of pyogen. This is an example of a patient who had lung lesion on a biopsy. On the left-hand side, we can see intranuclear inclusion bodies, very suggestive of CMV. On the right-hand side, again on a core biopsy in another patient, we see intranuclear inclusion bodies, very suggestive of herpes simplex and confirmed on immunohistochemistry. Tuberculosis, common in both immunocompromised and immunocompetent. The hallmark, as you can see on the left-hand image, is a caseating granuloma. It can be so much distorted like the one in the middle. Rarely people might be able to see the organism itself, which I have to say never came across. PCR is being advocated for as being helpful in the diagnosis. However, I have to say from our experience at KFSH, PCR has not been positive in the majority of cases, and we often waited until a culture is done or rely on a morphology of caseating granuloma. I'm going back to this case because we said that we did an FNA. However, I have to say that identifying the morphology, whether on FNA or core biopsy, is not enough. And remember, for these patients, they are sick, and there is a need to further verify that, perform cultures to confirm the organism, in addition to performing susceptibility testing. As a matter of fact, in this patient, susceptibility testing was done and her anti-fungal treatment was modified. So when we talk about adequacy of sample, we have to also talk about preparation. Remember, we always start with sterile specimen for cultures and susceptibility testing whenever infection is raised, even if it's for a small percentage. And I always remind the fellows in particular, when they start, please make sure that we don't need cultures, because if that's the case, that's the first sample you want to withdraw. And usually I send at least two, one for fungal and one for AFP. Fixation, obviously, for all formalin is good enough. However, if there is a suspicion for certain types of lymphoma, and in particular your lab depends on flow cytometry, you might want also to have a sample without fixation, so in saline. If you do viral cultures, you might also want to make sure that the samples are being transported as soon as possible, because they tend to lose their validity if you delay them more than 15 to 30 minutes. Targeting the lesion is extremely important. This is the case I have shown you before. And I said it's complex because we were concerned about infection. Everybody else thought it was cancer. We did a first transthoracic needle biopsy. Unfortunately, it was limited to FNA. There was necrosis, negative for PCR. Patient then went for EBUS. FNA showed necrosis, negative PCR, no cultures. And then finally, we did a second biopsy. And at that time, I made sure that when I do it, I cover central and periphery. And I'm going to talk about that why in a bit. And then we send it for culture PCR. We did all the panels, and we used both an aspirate as well as a core specimen. The histopathology showed necrosis, negative for PCR. So the pathologist said, well, I cannot confirm TB. The patient went to the OR because the surgeon was so much convinced that this is a cancer. And then I think it was a Thursday afternoon when he picked up the phone and called me and said, Masha'al, we opened the patient and there was all pus, so we had to close again. I think it was 1 week after that 1 out of 3 cultures came positive for TB. Now, why am I giving you this very long story about this case? Because unlike the common thought that it's easier to diagnose infections, my experience is that they're actually much harder. And one of the reasons is that lung reaction in infections tend to be more diverse and complex than it is in tumor. Because they sort of appear relatively quickly over time, they tend to compress the surrounding lung rather than involving them. So you have always a periphery of atelectasis. In addition, inflammation will be midway. And then unlike the central necrosis that we often try to avoid in neoplasia, it's actually one place that you want to target in in infection, in particular in immunocompetent patients. And this is because pathogens will actually be seen in abundance. So to answer the question, periphery or center, I actually go for both, and I'm actually very vigorous even when the suspicion is for infection. Last but not the least, regarding adequacy of sampling, is related to safety and access. This is just like any other interventional procedure. We have to avoid fissures, be aware of airways and vessels. However, even though we often advocate shortest trajectory, I have to say that sometimes you might be pushed to actually go away from the shortest trajectory and use a normal lung window to minimize risk of fistula. This is in particularly true if you have a large area of necrotizing pneumonia. Last but not the least is decision-making and treatment. And this is probably the most important part. Decision-making has been shown to be affected when percutaneous biopsy is used vigorously when an infection is suspected, and the change in antimicrobial therapy can be seen up to 36%. I did talk about variabilities in practices, but I have to say that vigorous sampling have been sort of advocated for because it would ensure susceptibility testing. So starting the treatment early on in a very targeted way, alter treatment for unsuspected cases. I'll show you an example. And then minimize drug resistance, which is becoming extremely common nowadays. This is a case from my fellowship training, a patient who was post-stem cell transplant, presented with febrile neutropenia. Unfortunately, the patient was deteriorating gradually despite empirical antifungal treatment. We did an FNA because that was the practice, and it showed only non-specific findings in terms of lymphocytes. But then it wasn't enough. We scheduled the patient for a CT-guided biopsy, but unfortunately the patient died. And on autopsy, a post-transplant lymphoproliferative disease was confirmed, which is obviously caused by EBV. Now, it was unfortunate for this patient. However, if we were able to diagnose it on time, I would say PTLD is one of the diseases in which the prognosis is extremely good because they can be altered by just changing the immunosuppressive regime for the patient. And we have seen a good number of cases here at our institution. This is a patient who kept haunting us. I'm sure my colleagues from KFSH remember this case. He is a patient with granulomatous polyangiitis, or also known as Wegener's. This CT, I think, was from 2016. There was a question about his compliance to treatment, but clinicians wanted to optimize his immunosuppressive therapy, but they were concerned about infection. They requested CT-guided biopsy, which I have rejected. And my argument is that if he's non-compliant, then I think the picture and the history are all going with the fact that this is part of the patient's own disease. Multiple cavitating and non-cavitating lesions. However, they ended up convincing one of the radiologists to do the procedure. Obviously, it was negative. But if it was up to my choice and if they needed sampling, I personally would have gone for a transbronchial and BAL simply because it would allow multifocal access or multilobar access compared to CT-guided. So they did intensify the patient treatment, but again, a few months ago, he came back. And this time with this sort of solid lesion that enlarged compared to a prior one. And this time I thought of something completely different. I said, well, you are worried now about an infection. I don't think the patient is having an infection. This doesn't look like an infection. But because it's enlarging and because it has been there for a while, I am concerned about lymphoma. But obviously, when I did the CT biopsy, my eye was on the fact that this could be an infection. So we had to send all the samples for cultures. Finally, we did the CT-guided biopsy. And as you can see, we can see granulomas that are very suggestive of Wegener. It's not typical of caseating. So this is not TB. And we did not see organisms. All cultures were negative. And the good thing, it's also not lymphoma. So even though the clinicians were concerned about infection, which we were not concerned about, we had to do the CT biopsy and include cultures, which ultimately came negative. So in summary, I hope I have given you a good overview about the value of transthoracic needle biopsy. I think it's quite helpful in both patients with low and high suspicion. I think we have to pay attention for optimal sampling, which is often overlooked in my humble opinion. This will include both thinking about the type of organism and what kind of sample you need. Last but not the least, I cherish a lot my relationship with my colleagues in multidisciplinary teams, my relationship with the pathologist. And I often, if not always, would discuss my cases either immediately before or immediately after. In particular, when it comes to infection or unusual presentations of neoplasms, it's good to discuss with the pathologist so that the samples can be used efficiently and panels can be actually applied in a more efficient way, reaching to the diagnosis. I hope I didn't step too much over my time, but that's it for me, and thank you.
Thank you very much, Dr. Masha'il. Amazing overview and review for the TTNA. I have two questions for you from the audience. The first one is, when performing biopsy for lung infection, does it have to be a mass or mass-like consolidation, or do you biopsy pure consolidations or 3-in-bud opacities?
Tough question. A good one. Usually, I would say I would avoid consolidations in general. There are only few occasions where I've done them when patients were really sick and they needed an answer. If we have an access for PIT, I find PIT helpful a bit when it comes to consolidation, because it also would direct you to areas of yield. But I would say the yield overall from the literature and from my experience, since I only have done few, is really very limited. But we push for it when we think the patient might benefit from it.
Thank you. And the second question is, so for every specimen, do you send it to histopath and microbiology, or it depends on the CT morphology? And does it influence the approach of biopsy?
So invariably, we always, I would say nowadays, do core biopsy no matter what. However, when there is a question of infection, I would take few samples initially from the more necrotic areas, and I would drop them into sterile containers. So that would replace sort of the FNA part. Sometimes it's so much liquefied that I would just aspirate it with a needle. But the most important is that you don't get those samples to be contaminated with formalin. And that's it. So yes, I would sample both if I have to. Well, I would do both, sort of histopathology and culture. I would always do it.
Thank you very much. Thank you.
So I hope it wasn't very challenging to listen and learn from home. And I hope you enjoyed our today's journey with us today, as I hope that it was very fruitful. Organizers, speakers, and participants, thank you very much, and hope to see you in the near future. We may call all of the speakers and the panelists now for more discussions and questions.
No questions?
No questions from the audience.
So with that, we conclude. So again, to announce that these lectures are recorded on the website for anytime viewing, and certainly